Hi, my name is David Montgomery, and today we'll be going through an examination of the shoulder. Thank you very much, Joe, for taking time to volunteer to be a part of this. So, before any shoulder examination, it's important to do a full assessment of the cervical spine and the kinetic chain and core instability. So, can we start, Joe, with placing your chin to your chest, chin to the sky, look over your left shoulder, look over your right shoulder, ear to your left shoulder, and ear to your right shoulder. Was there any pain during those movements? No. So the movement was symmetrical and there was no evidence of any tightness throughout. Now I'm just going to feel on top of the head, bit of pressure. Does that replicate any numbness, tingling or pain down either of your arms?
No.
No. Are you able to feel me touching you on both sides? Does it feel the same both sides?
Yeah.
Excellent. So there's no evidence of radiculopathy. Now we're going to begin by looking at the kinetic chain and core stability. So can I ask you to do a one-legged squat for me, please? So he has mild internal rotation of the knee, good stability at the pelvis, and some instability in the torso. Now to exacerbate the feeling of instability, we're going to place an unstable surface, in this case a pillow, and ask Joe to replicate that. So more internal rotation at the knee, some evidence of pelvic drop, the torso was relatively stable. And the findings are consistent with some evidence for kinetic chain and core instability, which can exacerbate shoulder problems in a throwing athlete. Thanks, Joe. Ideally, we would assess both sides, but for the sake of this examination, we'll be only focusing on one, the same for the shoulder. You should always compare it to the other side. So now going on to start, we're going to look at the general alignment and posture. Joe has a very straight back, good posture. There is equal elevation of the shoulders, no evidence of scarring or bruising or any muscle wasting. The pectoralis major appears to be equal both sides. If you can turn around for us, please, Joe. Looking at the back, again, no evidence of scarring or muscle wasting, either in infraspinatus or supraspinatus fossas. We can see that the shoulders, possibly some slight elevation on the right shoulder, although minimal. Excellent, you can stay there for a second. And now we're going to go through, similar to the kinetic chain, but assessment of the shoulder movement, looking for any scapular dyskinesia. So Joe, for that I'm just going to ask you to push your shoulders back for me, and now forwards, up and down. So looking throughout that range of movement, looking to see that it is equal elevation and equal speeds and movement throughout, which it was in that case. Now hands on your hips for me, please. And again, backwards, forwards, up and down. Excellent, and back to normal. Lovely. So again, nice coordination throughout. From this position, we can check to see the scapular glide. So if you can push your shoulders back for me, please. We see in the midline, and then relax. So the midline to the medial border of the scapula, and again looking now on the left hand side, we can measure it as well. Look back for me. Narrow sign, yeah, and out, relax. So it's about equal glide both sides. Now if you put your arms by your side, out by your sides for me, yeah, and now push back, forwards, up and down. Lovely. Now arms in front, straight ahead like Superman, yeah, lovely. And then slowly raise them above your head, looking for scapular control throughout, which is equal, and then down by your sides, please. Lovely. So there's good control throughout. Mild slowing on the left side compared to the right would be suggestive of some evidence of left-sided scapular dyskinesia. To complete the examination, Joe, I'm just going to ask you to do a press up against the bed for me, and we're looking for any winging of the scapula out or winging the scapula up and up, which is not evident. Lovely, you can stand up, thanks. Turn around. So now we're going to begin by general palpation, a complete systematic palpation of the shoulder. We start at the sternoclavicular joint, palpate along the clavicle to the acromioclavicular joint. Any tenderness along there?
No.
Any tenderness in the AC joint would be suggestive of AC joint pathology or osteolysis of the clavicle. on the anterior aspect of the clavicle, the acromion, any tenderness would be suggestive of shoulder impingement. Just in front, inferiorly, is the coracoid process, which is where the insertion of one of the two heads of the biceps. We can feel anteriorly in line down here and roll our fingers along it. We can roll our fingers along the biceps tendon. Then at the anterior axillary fold is made up of the pectoralis tendon. If we abduct the arm and resist against me, pull down, we can feel along with the pectoralis tensing, we can feel along the pectoralis tendon. Lovely, you can relax down. Now if you turn round for me, posteriorly, we can palpate on the spine of the scapula and on the medial border of the scapula for any tenderness, and then feeling on the posterior aspect of the acromion may be consistent, if there's any tenderness there, be consistent with a slap tear. Maybe turn back around for me, please. So now we're going to move on to the range of movement in the shoulder. So first we'll do actively assessing the entire movement throughout the ball socket and the scapula before passive movement isolating glenohumeral joint motion. So first I'm going to ask you your hands straight in front of you, all the way up as high as they can go. So there's active flexion to 180 degrees and back down. Lovely. And now out the side, all as far as I can go. And active abduction to 180 degrees. Now if you drop your arms down to about 90 degrees and bend the elbows 90 degrees, try and reach your palms to the sky. Active flexion to 90 degrees and down to the ground. Active flexion to 85 degrees, and you can relax. Lovely. We're now going to go and assess passive range of movement, but to do that we have to stabilize the shoulder. As soon as we can feel the scapula start to move is when we deem the true end of glenohumeral motion has occurred. So going through forward flexion, we can get to there, it's about 110 degrees down, and now passive abduction to get to 90 degrees down. Now in this position we do internal rotation, there, 45 degrees, external rotation, 80 degrees. Lovely, you can relax. Excellent. So there's good range of movement throughout. So now we're going to progress and have a look at the special tests of the shoulder. First of all, looking to assess for any evidence of a slap tear. The first of the tests will be a series described by Kuhn, the first test of which is Jurgensen's test. So the arm by the side, Joe resist turning your palm up against, or push your palm up against me. So resisted supination will cause tenderness in the biceps tendon if there's any evidence be positive. The first test will be positive if there's any pain. The second test is abduction and inferior distraction. So again, any tenderness or pain in the shoulder. If there was, that would be consistent with a positive test. The final test is a distraction test, pulled inferiorly on the shoulder, and if that replicates any pain, that's a positive test. It can also be used for the assessment of instability, where you'll see a sulcus or a valley sign here in the presence of inferior instability as the glenohumeral head moves inferiorly, and the humeral head moves inferiorly. So moving on from that, so in the series of those three tests, where all are negative, it's consistent with less than 6% chance the presence of a slap tear. One is positive, there's a 15% chance, and where there's two, it's a 35 to 66% chance, which would then, in those situations, likely require an MRI and an arthrogram to compare. We can move on to the crossover test and cross over the body, which can cause pain in the AC joint, the AC joint separation. If that's absent, turn the thumb down and do posterior inferior compression against resistance. The thumb down is O'Brien's test. If that replicates pain in the shoulder, that's consistent with a slap tear. Turning the thumb up and pushing inferiorly. If that improves symptoms before going back into O'Brien's down, which exacerbates symptoms, it's a positive slapprehension test. We can then move into the Mayo-Kranken-Shear test. Stabilizing the shoulder, we're moving posteriorly through the full range of movement, looking to feel for any clicking, popping associated with pain, and that would be suggestive of a slap tear. Going into resisted forward throwing motion, so I'll push against my hand. So if any pain on resistance is suggestive of slap tear. From this position we can move into the biceps provocation test described by Kim. turning the hand into pronation, puts strain on the biceps tendon and on any evidence of the slap tear if it's there. Turning the hand back towards the head, pull against me, flexes the biceps and will be painful in the evidence of biceps tendinopathy or a slap tear. With the arm front, hand side, and resist moving forward against me. So against forward flexion, keep the arm straight. Move against my hand. If that causes any pain here, that would be a positive speeds test. So that completes our examination for slap tear. We move on to any impingement. So that is any evidence of rotator cuff tendinopathy or bursitis where it becomes inflamed under the acromion. So to start, arms by your side at 90 degrees, resist pushing against me. Checking external rotation, assesses infraspinatus teres minor. Internal rotation, assesses subscapularis and pectoralis major. To isolate subscapularis in the zone, try and pat your belly against resistance, Joe. Isolated subscapularis. If you turn around for me, place your hand on your lower back, try and lift your hand off against my hand. This is Gerber's lift-off test. If there's pain, that's positive, again suggestive of subscapularis tear. Moving the hand out in abduction with the thumb down, called the empty can test, and pushing down against it is if there's any pain, suggests supraspinatus tear. If the arm were to give way entirely, that would be suggestive of a complete supraspinatus tear. To complete the assessment for shoulder impingement, we can do Neer's test, where hand goes in anteriorly, inferiorly underneath the acromion and forward flexes the arm, looking to try and catch any impingement under the fingers. If that causes any pain, that would be a positive test. Keeping the hand in neutral position, elbow bent, if we internally rotate the arm in this position, if that causes any pain, it's catching the greater trochanter against the acromion in Hawkins test, be positive for impingement. So having completed those tests, we will now move on to assess for any shoulder instability. But before we do that, we want to see if there's any generalized ligament laxity. So we'll do that by completing the Baton score. First of all, we'll have assessed the 5th MCP joint, looking to try and hyperextend and dorsiflex greater than 90 degrees. It's not there. Comparing to the other side, it's just not quite 90 degrees. Try and apposition the thumb to the flexion compartment of the forearm. No. Each one of these, if present, will get 1 mark. Now we look at the elbow, try and hyperextend it greater than 10 degrees. No. And on the other side, yes, just greater than 10 degrees. If you can have a seat for me. Again, looking compared to the knees, trying to hyperextend greater than 10 degrees. On the other side, no. Now if you can hop up with your feet beside each other and try and put your palms flat on the floor, which he is unable to do. Thank you. So Joe scored a 1 out of 9 on the Baton score, which suggests there's no evidence of generalized ligament laxity. A score greater or equal to 4 would be suggestive. So from this position, we can do a load and shift test. We stabilize the shoulder, put a hand anteriorly and posteriorly on the humeral head, try and translate it anteriorly and posteriorly, looking for looseness, any apprehension, or any clicking or popping. That would be suggestive of interarticular pathology. It is non-specific. From this position, we can then go into the apprehension test. So we want to abduct and externally rotate with the thumb at the posterior aspect of the humeral head with anterior traction. This increases and maximizes the sensation of instability. If there's any apprehension, that's positive for instability. So from this position, we'll ask Joe to lie on the bed for us, and we're going to complete the examination lying down. This stabilizes the shoulder, so we can assess true glenohumeral ligament laxity. We want the shoulder positioned off the side of the bed, which is excellent there. You want to take all the weight in my hand, Joe. I have your thumb. Try and relax the arm nicely, so you push down on the humerus, and then you hold onto the humeral head and translate anteriorly and posteriorly, looking for any generalized laxity. That's good. From this position, you want to do the crank test, stabilizing the shoulder, moving it through full range of movement for any clicking, popping, or any reduction mechanisms where subluxed and you can see it reduce, which is not present in this position. Again, we can go into an apprehension test, where pushing the humeral head anteriorly and going into abduction and external rotation. If there's any apprehensive signs, then you can do a Jobs relocation test. Doing a posterior force on the humerus relocates the humeral head, and a significant improvement in the apprehension symptoms. Alternatively, in that position where there's pain rather than apprehension, and Joe's relocation improves pain, that's suggestive of a slap tear. Thank you very much, Joe. You can put your top back on. So that completes our examination of the shoulder.